I have some notes on the patients we saw that I want to talk to you about.
Let's go ahead and get started. Everybody take a seat. Just a couple of announcements. The word of the day is Ontario, in honor of our Canadian colleague and friend. And I'm supposed to tell people, anybody parked down or below, you need to stamp your ticket. Apparently last week there was some confusion about that. So it's really an honor to have Param Nair here, a friend of our program and someone who's been a visitor before and really one of the leading people in the entire world in studying the pathophysiology of severe asthma. Really the world's leading expert in induced sputum analysis. His work Drew was in his fellowship. And so today he's going to give us a talk entitled Novel Mechanisms of Persistent Airway, Eosinophilia, and Severe Asthma. So thanks very much for coming. Thank you.
Thank you very much, Len. It's a privilege to be invited back here. I've had the honor of collaborating with Len on a project a few years ago where we tried to measure markers of remodeling in sputum in collaboration with Tom White at the Benroya. And I'm not going to talk about that project here, but we're going to extend that to patients with chronic airflow limitation and diffuse parenchymal disease and make these measurements in sputum and relate it to CT images of remodeling using advanced measurements of quantification such as parametric response modeling. We won't talk about that. Today I'm going to talk about a translational program in Hamilton in my lab where we are trying to unravel mechanisms of persistent bronchitis in patients with severe airway disease. What I mean by persistent bronchitis is what that does not respond to even high doses of corticosteroids or prednisone, who get recurrent infective bronchitis that may in turn contribute to persistent eosinophilia. It all starts with a very, very simple schema developed by my mentors, Jerry Dolovich, who was one of Canada's leading pediatric allergist, immunologist, and Freddie Hargrave, a wonderful physician scientist who long before biomarkers, personalized medicine, phenotyping became buzzwords, were implementing personalized, individualized care for about 25 years. It all starts with a very, very simple concept. Patients come to us with respiratory symptoms, and we tease them apart into the components that might contribute to the symptoms rather than just treating symptoms. We assess chronic airflow limitation or variable airflow limitation based on measurements of spirometry, airway hyperresponsiveness based on measurements of direct or indirect provocation, and most importantly, bronchitis based on quantitative cell counts in sputum. So rather than treating a disease label of asthma, which is variable airflow obstruction, or COPD, which is chronic airflow obstruction, we would understand the component that contributes to symptoms and treat the component. If the patient had persistent eosinophilia, we use corticosteroids. If the patient had persistent neutrophilia, which we could identify as either bacterial or non-bacterial, that would help us guide antibiotics or not use antibiotics. Or if the patient's symptoms were driven by hyperresponsiveness without a steroid-responsive bronchitic component, we would refrain from using corticosteroids even if the disease label was asthma. This is the Dutch hypothesis, and Freddie once got into trouble when we published this, when a friend in England who phoned him and said, look, this is high treason for an Englishman to promote the Dutch hypothesis, and had he been living in England, he would have risked being sent to the Tower. But we carried on, and our patients are so much better for that. And to give you a historical perspective, the sputum examination is not new at all. We have been using sputum examination for over 100 years. Goulash first reported its use in about 150 years ago. Paul Ehrlich examined sputum. This is not a new concept at all. But what was new was the introduction of the principle of dispersing sputum so we could make good smears. And Peter Gibson, who now is a professor of respiratory medicine in Australia, Newcastle, introduced that concept. And later, Isabelle Pan from France, who worked in Hamilton, introduced a concept of using hypertonic saline to collect sputum even in patients with asthma. Until then, we would not use hyperosmolar stimulus in patients with asthma for fear of risking inducing bronchoconstriction. And then Ted Popov, who joined the laboratory from Sofia University in Bulgaria, introduced a concept of examining cytospins rather than the traditional smears. Then a couple from Brazil, Emilio and Marcia Pizzichini, validated the whole concept of quantitative cell counts, the validity, the normal values, the repeatability and responsiveness of quantitative cell counts. And when I was recruited to the laboratory in 1996, the task was all done. I had a relatively easy task. Freddie entrusted me with the task of applying this to clinical practice to show its utility in managing patients with severe airway disease. And my research program over the past 12 years that I've had my own laboratory has been a very simple concept, the 3M of bronchitis. Simplify measurements, and we are now developing point-of-care tests to measure eosinophil and neutrophil activity by putting eosinophil peroxidase and myeloperoxidase on a bioactive paper by developing a microscale paper analytical device which you could dip into unprocessed sputum to get a quantitative assessment of cellular activity that patients could self-manage or physicians could use in their office. Once you identify persistent bronchitis, we need to understand the mechanisms. And once you know the mechanisms in patients who have got persistent bronchitis, despite the usual treatment that we give them, we could then target the pathways that lead to the particular bronchitis, which is what I'm going to talk about today. I'm from a province in India called Kerala, and Kerala is a land of coconut trees, and when I grew up, we were taught to use every bit of the coconut tree. So I applied the same principle to using sputum. We use every bit of the sputum sample that we collect in the laboratory. So we have moved it from a research tool to routine clinical test. Sputum is induced in the pulmonary function laboratory. We do about 15 inductions a day for patients with complex airway disease. The quantitative cell counts are captured on a database. We have now got a database of 15,000 patients. And the interpreter report is faxed back to the referring physician the same evening. The rest of the sample is stored and used for research purposes. So the non-squamous component of sputum is used for microbiome studies, and I'll touch on this briefly. We do extensive extended cultures, anaerobic carbon dioxide enriched media cultures, and if necessary, 16S deep sequencing. The supernatant is stored for biomarker discovery and for proteomics, and the cell pellet is used for isolating specific cell types that we are interested in for specific research projects, for flow cytometric assessments, for surface markers, and for intracellular cytokine measurements, for special microscopy. We have initiated a project now to understand the elemental nature of what is inside macrophage using Raman spectroscopy, RNA extraction for microRNA research, and gene expression profiling. So it's a wealth of information that we can get out of the humble sputum pellet. You don't need to do a bronchoscopy or bronchoalveolar lavage. The patient obliges, they do most of the work. And I always say you don't have to do the induction most patients, and half of the world's population is now Indians, and we have naturally gifted spitters. You can skip the induction there. You don't need to use sputum in every patient. So Bill Calhoun in Galveston, Texas, had done a very elegant study to demonstrate that for most patients with asthma, or for that matter, chronic obstructive pulmonary disease or chronic cough, you do not need any biomarkers. Your traditional guideline-based treatment is good enough. You need biomarkers only for those patients who physicians find difficult to treat. And in my personal experience in Hamilton, we use it only for 4 groups of patients. We use it for patients who are referred to us, for whom the referring physician believes they need daily prednisone or frequent bursts of prednisone. We really need to know if the prednisone use is appropriate and what is driving this prednisone requirement. Secondly, patients with recurrent exacerbations of COPD. Now, this is a completely recognized utility of sputum examination. The general concept is it's only useful in patients with asthma. It's not true. We know that the best predictor of a subsequent exacerbation is a previous exacerbation. Clearly, it could also mean that the previous exacerbation was poorly treated, and therefore the patient has subsequent exacerbation. Sputum examination for COPD is critically useful to identify those patients who need corticosteroids, and more importantly, those patients who do not need corticosteroids to treat their exacerbation. Thirdly, for patients who get recurrent infective bronchitis, colored sputum could be patients with bronchiectasis, non-CF bronchiectasis, asthma, or chronic bronchitis due to cigarette smoking. And finally, very, very important, patients with chronic cough. Eosinophilic bronchitis in a tertiary clinic accounts for about 30% of chronic cough that is not responsive to the usual treatment. So if you look at the heterogeneity of bronchitis, now I'm going to talk about just asthma for the rest of my talk. This is data from about 2,000 patients. The majority of patients, about 67% of patients, at least in a referral practice, tertiary care referral center, at the time of exacerbation would have eosinophils in their sputum. Now, I'm not implying that eosinophils are contributing to that exacerbation. We'll come to that later. But they have an eosinophilic inflammation which would give a T2 type signal to the airway disease. It may not be all Th2, as we will discuss later. About 10 to 15% of patients would have an intense neutrophilic bronchitis that's almost invariably due to an infection. Our own data suggests that this concept of neutrophilic asthma is a reflection of the high doses of corticosteroids that are used to suppress the eosinophilia or an altered microbiome that is unrecognized. A smaller proportion, about 10% of patients, would have a combined eosinophilic neutrophilic bronchitis. This group is very, very important. It's the most difficult to treat, and we will touch upon that a bit later. And about a small proportion would have completely normal cell counts at the time of exacerbation. Acellular, their exacerbation is probably not due to bronchitis. Now, if we focus on the 67% who have got persistent eosinophilia, in our clinic, it's a reflection of the referral practice. Only a very small proportion of patients are on low-dose inhaled corticosteroids. It's simply because we work in a tertiary care center. Majority of patients will be on very high dose of inhaled corticosteroids, and a small proportion, about 10%, would be on daily prednisone. So if we put together patients who have got combined eosinophilia and neutrophilia, and patients who have persistent eosinophilia, a total of 1,200 patients, about 10%, about 120 patients in my practice will be on daily prednisone, and I'm going to focus the rest of my talk on what could be driving this persistent eosinophilia and need for prednisone in these patients. The most important in any clinic would be abnormal steroid pharmacokinetics for whatever reason, starting with poor compliance, which, by the way, is the most important cause of persistent eosinophilia. Literature from the National Jewish in Denver many years ago had suggested abnormal methylation, absorption profile of prednisone in some patients, which have really not been rigorously tested in clinical trials. There is an indication in the literature of abnormal isoforms of steroid, the beta isoform, that might contribute to steroid insensitivity. Very elegant ex vivo literature, but less convincing literature in clinical studies. But I'm going to process on three processes that I think are relevant in our patients with severe asthma, and the direct translational relevance of this with the advent of new monoclonal antibodies that could target these pathways, particularly local processes that are responsive to usual therapy. What I mean by local processes is there might be less dependence on recruitment from blood, with local maturation of eosinophil progenitors into eosinophils, mature eosinophils in patients with severe asthma. Steroid insensitivity due to an imbalance between histone acetylase and deacetylase activity, possibly mediated by microbiome. And finally, direct effect of infections on decreasing steroid sensitivity and what we could do about that. So the objectives would be to discuss the role of the newly described immune cells, the innate lymphoids type 2 cells in sputum and severe eosinophilic asthma, discuss the potential effects of airway microbiome on steroid insensitivity, discuss the possible interaction of microbiome and HDAC, and finally some very new data from our laboratory, which we haven't published, on the possible role of a local autoimmune process in severe eosinophilic asthma, and the concept being that patients with eosinophilic asthma have a lot of eosinophil peroxidase in their airway. And as you know, peroxidase anywhere in the body could be immunogenic. Thyroid peroxidase induces autoimmune thyroiditis. Myeloperoxidase induces P-ANCA disease. So why would eosinophil peroxidase be any different? Is it at all possible that patients with severe eosinophilic asthma may have a component of autoimmune disease that might drive the dose of steroids required to control the eosinophilic process? In patients with severe asthma, how dependent is recruitment from blood? In order to test this hypothesis, we did a randomized controlled trial that we published last year, where we administered an oral small molecule antagonist against CCR3, which is the receptor for one of the most potent chemoattractants for eosinophils, eotaxin-1. In 50 patients with moderate to severe asthma, half of whom received the CCR3 small molecule antagonist and half of them received placebo, which is a multi-center Canadian trial. Now, the molecule had 95% receptor occupancy and ex vivo induced the appropriate changes on eosinophil shape, indicating that this was potent. However, as you can see, the active molecule on the bottom right panel compared to baseline did not cause any significant decrease in luminal eosinophils after 10 days of dosing compared to the placebo on the top left panel. All patients received a 5-day course of prednisone, which suppressed luminal eosinophilia completely, showing that the eosinophilia could be suppressed with prednisone. So the point I want to make here is a potent anti-eotaxin inhibitor. Well, it's not a direct eotaxin-1 inhibitor. There's only one eotaxin-1 inhibitor monoclonal available, bentralizumab, which is undergoing clinical trials. It's an immune pharmaceutical Israeli-based company's compound, but this is a CCR3 antagonist directed against, it's a small molecule antagonist. But the point I want to make is that we could not suppress luminal eosinophil despite inhibiting eotaxin. It could mean one of two things. Either there are other potent mechanisms other than eotaxin that is involved in eosinophil recruitment, and all the animal studies implying eotaxin as the most potent chemoattractant for eosinophils, at least in airway disease in humans and severe asthma, may not be true. It might be eotaxin-3 acting through a different receptor. It could be other chemoattractants, RANTES, acting through other receptors. Or perhaps the intriguing concept that there might be local maturation of eosinophils, and which is less dependent on recruitment from blood. In our same study, we enumerated eosinophil progenitor cells, which are CD34 IL-5 receptor alpha expressing cells, which have the propensity to differentiate into eosinophils, and we did not find any effect of this inhibitor on progenitor cell recruitment either. But if we give an intravenous anti-IL-5 monoclonal antibody, mepolizumab, in these severe prednisone-dependent patients, we can suppress the sputum eosinophils in every one of those patients. This is data from 6 years ago. Very potent molecule. This was a proof of concept study. All the patients who received the monoclonal antibody had complete suppression of both blood and sputum eosinophils, with an ability to decrease the dose of their prednisone with an 87% dose reduction in prednisone. In contrast, if we take the same group of patients and give them subcutaneous mepolizumab, mind you, there's a difference. We used a lower dose of the molecule, 100 milligrams, as opposed to 750 milligrams in the previous study. And the route of administration here was subcutaneous, whereas the previous study was intravenous. In every one of those patients, this is data from 15 patients from our own laboratory, you could suppress blood eosinophils in every one of those patients. So if you monitor blood eosinophils, you would think you're doing a good job. If you look at the overall data, which was published in the New England Journal of Medicine last year, 50% of patients on average, had a 50% dose reduction in prednisone, which is statistically significant, whereas in the previous study with intravenous, 100% of the patients had a dose reduction of 87%. Now, 50% of these patients, we could not suppress the sputum eosinophils, whereas all of them had suppression of their blood eosinophil. So this gave us an opportunity to study the discordance between blood and sputum eosinophils in patients who are prednisone dependent, who remained uncontrolled despite subcutaneous administration of mepolizumab. Could it be there is a local source of IL-5 that is not suppressed? Could it be possible that this local source of IL-5 may act on these progenitor cells, if at all they are present, and turn them into mature eosinophils without having to depend on recruitment from blood? And these new class of cells are a number of sources of IL-5, but one of them is this new class of cells, the innate lymphoid cells type 2, that are present in the airway, that have receptors to respond to IL-33, the ST2 receptor, and to TSLP, the IL-7 receptor, both of whom are alarmins that are derived from epithelium. And these ILC2 cells express IL-5 and IL-13. So you potentially, if the ILC2 cells are activated in the airways of patients with severe asthma, and if they produce IL-5 and IL-13, it is possible that the subcutaneous dosing with inadequate tissue penetration and with ineffective levels in the airway may not be able to suppress local IL-5 activity. ILC2 cells had only previously been demonstrated in animal models, and therefore we attempted to characterize these by flow cytometry in patients with severe asthma in sputum. The gating strategy that we used was this. We had lineage negative cells that expressed CD45. So they're CD45 negative. So these are lineage negative on the left panel, CD45 positive cells.
You can use the mouse, I think, as a pointer.
Oh yes, sorry, yes, it's working now. So these are lineage negative cells. So CD45 positive that express the ST2 receptor, which is a receptor for IL-33, and the IL-7 receptor, which is utilized by TSLP. Now, if you enumerate the ILC2 cells in patients with mild asthma and severe asthma, numerically, in blood on the left panel and in sputum on the right panel, we could demonstrate that the number of ILC2 cells are more in severe asthma compared to mild asthma in both compartments. But if you then specifically enumerate the expression profile of IL-5 in the top panel, IL-13 in the middle panel, or IL-5 and IL-13 co-expression in the bottom panel, blood on the left side and sputum on the right side, you would see that the IL-5 expressing IL-2 cells are increased in severe asthma compared to the mild asthma in blood. The IL-13 cells are also increased in severe asthma compared to mild asthma in blood. So are the ILC2 cells that co-express IL-5 and IL-13. In sputum, we could only demonstrate the ILC2 cells expressing IL-5 to be increased in severe asthma compared to mild asthma. Now, this could be a reflection of the sample size as well. We had to work with these numbers that we had of patients as well, very intense studies to do in patients with severe asthma. But the punchline is the discordance between blood and sputum eosinophils in those patients who receive prednisone and subcutaneous IL-5. Now, we would traditionally think that CD4 cells are the predominant source of IL-5 and IL-13 in patients with asthma. Indeed, if you look numerically at the number of CD4 cells in blood on the left panel, the sputum on the right panel, the CD4 cells are indeed more frequent than the ILC2 cells. These are patients who are on prednisone, mind you. But then if you look at the expression of IL-5 and IL-13 on ILC2 cells and CD4 cells in blood, again on the left side, this column here, or sputum here, you'd find that the CD4 expression of IL-5, IL-13 or co-expression is less than that of ILC2 cells, indicating that the CD4 cells and the expression of these cytokines could be suppressed by high doses of prednisone. In patients with severe asthma, the IL-5 and IL-13 expressing ILC2 cells are relatively steroid insensitive. Now, if we come to our patients who have persistent airway eosinophils, but no blood eosinophil, if you look at sputum ILC2 cells, there is no difference in total number of ILC2 cells. If you look at the IL-5 expressing cells, we could not find a difference. Now, these are patients who have been exposed to IL-5 as well. If you look at the IL-13 expression, really no difference between the control and uncontrolled. But every one of those patients who had persistent sputum eosinophilia had an increased expression of the ILC2 cells that co-express IL-5 and IL-13. At the moment, I do not quite know the relevance of this, but Richard Loxley published in Nature 2 years ago that this population of ILC2 cells that co-express IL-5 and IL-13 as a dominant cell type driving eosinophilia in a parasite infestation model, more important than the CD4 cells, in the presence of high doses of corticosteroids. So I believe that there is something special about this population of cells that co-express IL-5 and IL-13 that are resistant to treatment with IL-5 subcutaneous, low dose, and with prednisone. Now, how could we tackle this? 75% of these cells express the IL-5 receptor. We could perhaps capitalize on this for some therapeutic intervention. And what would they do? As I indicated earlier, it's possible that the progenitor cells in sputum might turn into mature eosinophils under the influence of these local sources of IL-5 and IL-13, possibly from the ILC2 cells. So we enumerated in a separate study the eosinophil total hemopoietic progenitor cells, these are CD45 cells, the eosinophil progenitor cells by colony-forming assays and by flow cytometry in patients with severe asthma, mild asthma, normals, and patients with chronic obstructive pulmonary disease as control. And here we are demonstrating a 10-fold increase in the progenitor cells in sputum in patients with severe asthma compared to mild asthma, and this is not reflected in blood. So it's entirely possible that these progenitor cells could differentiate into eosinophils, and in peripheral blood, these cells express spontaneous clonogenic activity, differentiating into eosinophils without us having to put in IL-5 in the culture medium. So the gist of all this is that there is a rich source of progenitor cells with niches in the airway, which we haven't demonstrated by biopsy, that have the potential to differentiate into eosinophils under the local influence of cells that are not suppressed by prednisone.
Question.
Yes.
Are these allergic or non-allergic asthmatics, or are these what for years we've called intrinsic asthmatics, people who clearly have an eosinophilic disease, apparently driven by local cells, but are not allergic individuals when an allergist tests them?
The question was, are these predominantly non-atopic individuals or atopic individuals? The answer is majority of these patients are non-atopic, as defined by, so it's a problem in how we define atopy. So the traditional way that I would define these patients are they're negative to skin prick test with a common 16 aero allergens and a normal total serum IgE. 75% of my patients that have reported these severe asthmatics fall in that category. 25% have atopy by the standard criteria. Now there's another intriguing concept whether these patients could have local IgE production, which could be driving some of these processes, and we're testing that at the moment, and if time permits we can talk about that later. So majority of patients we believe are non-IgE driven eosinophil recruitment, although I haven't rigorously tested a local source of IgE, and I'll come back to that later in the discussion regarding autoimmunity.
I think there's some work from Barry Kay's lab from years ago about exactly that point.
Yes, and from Hannah Gould's laboratory in King's College, London. Yeah. Sorry, yes.
Are there any of these cells in nasal polyps?
Absolutely. So nasal polyps, do demonstrate ILC2 cells. There is work that is currently under review, and there is work from Bob Schleimer's laboratory that suggests that some of the CRTH2 expressing cells in nasal polyps could be the ILC2 cells. So absolutely yes. Now, what is the role of IL-4 and IL-13 in bringing these progenitor cells into the airway? We showed a few years ago that both IL-4 and IL-13 can potentiate the migrational response of progenitor cells to STF1 by suppressing CXCR4 expression in the bone marrow, which would have retained these cells in the bone marrow, but promoting migration into the airway. So again, the concept would be that locally derived IL-13 could potentiate the migration of these progenitor cells, then move into the airway, which could then differentiate into mature eosinophils without having to depend on the migration of mature eosinophils from blood in these patients with severe asthma. So if you then look at the potential targets of treatment, to summarize what we've just discussed, disruption of the epithelium due to various triggers could release alarmins such as IL-25, IL-33 or TSLP. In patients with severe asthma, that could expand ILC2 population that express IL-5 and IL-13, which could bring in these progenitor cells into the airways, which could then differentiate into mature eosinophils, whereas in patients with milder asthma, here on this right side of the panel, it would be largely a CD4-dependent, IG-dependent, traditional recruitment of eosinophils, either directly through the IgE pathway or through the IL-5 pathway, without having to activate the alternate pathways of ILC2 cells. How could we treat these severe patients? We are now doing three clinical trials, with the fourth one under review. First would be to kill off all these ILC2 cells, because they express, 75% of them express the IL-5 receptor. So we are now doing a clinical trial with an anti-IL-5 receptor monoclonal antibody, benralizumab, which by its property of afucosylation and antibody-dependent cytotoxic killing would be able to kill off any cell that expresses the IL-5 receptor. The second study that we are doing is to see if it's simply a matter of route of administration dose. We demonstrated that 750 intravenous could wipe out luminal eosinophilia. And therefore doing a direct head-to-head comparison of subcutaneous with intravenous by selecting those patients who had persistent eosinophilia after being administered a subcutaneous monoclonal antibody against IL-5, by then giving them an intravenous antibody and re-enumerating the cell population. And finally, we have just got funding to do an anti-IL-13 clinical trial to see if by antagonizing IL-13 on the ILC2 cells that express IL-13 or express or produce IL-13, we could decrease luminal eosinophilia and decrease the migration of these progenitor cells in response to STF1. And finally, ILC2 cells may not be the only alternate source of IL-5, and therefore we are doing a complete characterization of T2 cells by flow cytometry in sputum, looking at whether CD8 cells and invariant cells, T cells and NK cells could also contribute to IL-5 and IL-13 in these severe prednisone-dependent patients. Now moving on to the concept of steroid insensitivity, which might be mediated by infection. If you go back to those patient population with persistent eosinophilia and neutrophilia, as you see on the left panel, they have the lowest FEV1. They have got the maximum impairment of quality of life and most symptoms. If you were to do a proteomic analysis in sputum of these patients, the cytokine that is most predominant in the group characterized by a pleiotropic response, combined eosinophilia and neutrophilia, is IL-6. And the IL-6 family of cytokines, mediated by IL-23. If we were to do advanced cultures and 16S sequencing in these patients with severe asthma who have got a persistent neutrophilia and eosinophilia, traditional culture methods in core laboratories across the world would identify pathogens in about 10% of samples. But if we were to do extensive anaerobic cultures and 16S sequencing, we would be able to find a pathogen or a bug, what we would think in clinically relevant in greater than 10 raised to 6 colony forming units in almost every one of these patients. If you look at the microbiome of these patients with persistent neutrophilia, you'd be very surprised. In a hierarchical, unbiased cluster analysis, the pattern looked almost similar to that of cystic fibrosis, except there's no Pseudomonas. So in other words, what I'm indicating is that these patients with persistent eosinophilia and neutrophilia have an unrecognized microbiome, which would be dry, and the IL-6 response is simply an innate immune response to an altered microbiome. Now, how could that possibly contribute to steroid insensitivity? So we worked on this concept that infections, by increasing type 2, type 1 cytokines, particularly interferon gamma and the IL-6 family of cytokines, could upregulate microRNAs, non-coding RNAs, particularly microRNA 9, that would then inactivate a protein phosphatase A2, therefore leading to unopposed kinase activity, particularly J and K, which would then phosphorylate the glucocorticoid receptor and cause ineffective translocation and therefore ineffective clinical efficacy. In order to prove that, we collaborated with Paul Foster at University of Newcastle in Australia. So here is sputum sample on the left panel of patients with persistent eosinophilia, and on the right panel with patients with persistent eosinophilia and neutrophilia. We extracted RNA in sputum and enumerated microRNA, and the expression of microRNA 9 was significantly higher in those patients with a pleiotropic response. If you were to then isolate the macrophages in both animal exposed to a combined LPS interferon gamma, which is a model to mimic an infection in the mice that we studied. I did not do these experiments. They were done in Professor Paul Foster's laboratory in Newcastle, or in human sputum macrophages, we could demonstrate a time-dependent upregulation of microRNA 9. Now, if you then look at the expression of microRNA 9 in response to LPS, or a control, which would be scrambled sequence, or an antagonist of microRNA 9, Entagomia 9, you could see that this could be suppressed. The protein phosphatase 2 catalytic activity could be restored when microRNA 9 is inhibited. And the activity, the expression and the activity could, the expression on the middle panel and the activity specifically in macrophages could be restored when we inhibit the protein phosphatase A2. Consistent with the hypothesis, it demonstrates an inhibition of translocation to the glucocorticoid receptor, which could be restored when we use an inhibitor or promoter of protein phosphatase activity. To look at steroid responsiveness in the mouse model, the ovalbumin LPS model of hyperresponsiveness is not responsive to dexamethasone here on the left panel, and this responsiveness is restored when we treat the mice, with an antagomia against microRNA 9 compared to a scrambled sequence here. We then sacrifice the mice and look at tissue eosinophilia induced by ovalbumin and LPS here, which is not responsive to dexamethasone. That eosinophilia could be suppressed when we use an antagomia against 9. What we have shown is that an infection model in mice and confirmed infective bronchitis in humans could be associated with the persistence of eosinophilia, possibly mediated through microRNA 9. What I haven't shown is this is pathogen specific, and if we treat the infection, would the steroid sensitivity be restored, which are experiments that we are currently doing. we have taken our own patient isolates and we're putting those into this mice model to see if we could reproduce these results. It's unlikely that treating the infections the way we traditionally do with antibiotics would restore steroid insensitivity, because these processes have already been set in motion and we may need to inhibit microRNA 9 expression or at least promote protein phosphatase A2 activity, and these are experiments that we are currently planned. Now, what about histone deacetylase activity? As we know that histone deacetylase is required for the histones to be tight, the genes to be tightly coiled on histones, and the deacetylase is necessary for the uncoiling of the glucocortic for the genes on the histones, therefore exposing the glucocorticoid responsive elements for the steroid to bind to them. Very elegant work from Professor Peter Barnes' laboratory at the Brompton. Now, how does this happen? It's traditionally believed that patients with severe airway disease are under tremendous oxidative stress, and there is an inability to cope with this oxidative stress with a low NRF2 activity, which would lead to a decrease in histone deacetylase, leading to steroid insensitivity. It so happens that HDAC also regulates a macrophage scavenger receptor marker that is necessary for us to recognize infections and deal with infection. So we tested the hypothesis that patients with severe airway disease who truly require high doses of corticosteroids and who get recurrent infections may have a deficient HDAC activity with steroid insensitivity, which would also predispose them to recurrent infections. And from what I've just shown you, infections could make the steroid work less, and thus perpetuating a vicious circle. So we selected patients with prednisone-dependent asthma who required daily prednisone to suppress their eosinophilia, a control group of patients with moderate asthma whose eosinophilia could be suppressed with high-dose inhaled corticosteroids, and normal volunteers, and demonstrated that indeed those patients with severe asthma had an increase in phosphorylation of their AK2, which is consistent with the hypothesis here that low NRF activity and oxidative stress would increase phosphoinositol 3 kinase activity, increase AKT phosphorylation, which is what contributes to decrease HDAC. These patients also, on average, had reduced HDAC activity consistent with the previous data published from the Brompton. If you look at those patients with severe asthma who had recurrent infective bronchitis, they had lower HDAC activity and lower macrophage marker expression compared to those patients without recurrent infective bronchitis. Now, it would be very easy if we could just increase the HDAC activity by giving them something that we know can promote HDAC activity. It was not that easy. So all the compounds that, at least ex vivo, have been demonstrated to modulate HDAC activity, unfortunately in these patients with severe asthma was not able to increase it. We studied sulforaphane, low-dose azithromycin, low-dose theophylline, and nortriptyline, the 3 compounds that have been suggested to increase HDAC activity, at least ex vivo. Therefore, we are not able to demonstrate that any of these compounds could modulate HDAC activity. Brussels sprouts and broccoli sprouts are supposed to increase HDAC activity. The problem is you might have to eat 1 kilogram of that daily. Might smell like a bit of broccoli, but asthma might get better. So we have no idea. Perhaps extracts of broccoli, which we haven't tried yet. And finally, in the remaining 5 minutes or so, touch on the concept of autoimmunity. We already discussed that epithelial damage and persistent eosinophilia, and eosinophil-derived cytokines IL-6, IL-5, TGF-beta, and APRIL may lead to an expansion of a local ectopic B cell cluster that might cause loss of immune tolerance to eosinophil peroxidase in susceptible individuals, producing antibodies, either IgE, IgA, or IgG, against EPX. It's also an intriguing concept that EGPA, an extreme form of eosinophil disease, Churg-Strauss syndrome, is characterized by anti-neutrophil cytoplasmic antibody against myeloperoxidase, yet the infiltrating cell is eosinophil. It's not neutrophil. Myeloperoxidase shares 75% homology with eosinophil peroxidase. So theoretically, it's possible that these antibodies that we detect are perhaps not directed against myeloperoxidase, because that's the only assay that we do, but could be directed against eosinophil peroxidase. And perhaps it's also plausible that the ANCA negative patients may have anti-EPX antibody, not in the serum, but in the sputum. Therefore, we developed an analyzer to detect these anti-EPX antibodies, and this work was done in collaboration with Jamie Lee at the Mayo Clinic in Scottsdale. We looked at a sandwich ELISA, an indirect ELISA, and we pulled down the antibodies and characterized the antibody profile in sputum directed against eosinophil peroxidase. We can go into the experimental details if time permits. But the important data is that in patients who required high doses of corticosteroids to control their eosinophilia, we were able to demonstrate anti-EPX antibodies, largely the IgA type, with some being IgG. We have not been able to detect IgE or IgM antibodies, compared to patients without asthma and patients with a mixed asthma and neutrophilic asthma. Every one of these patients with high titer is on prednisone, suggesting again that this autoimmune process may contribute to the high steroid requirement. And we are in the process of understanding the clinical relevance, the isotypes, and the mechanism driving these antibody production in the airway. So this is my postdoc's view of theory of everything. Very complicated. You've got an intense airway eosinophilic response with release of eosinophil cytokines that leads to expansion of B-cell ectopic clusters, and patients who've got frequent exacerbations, either eosinophilic or neutrophilic, may have increased eosinophil peroxidase and myeloperoxidase with tissue damage, breach of tolerance, and with autoantibodies directed against tissue antigens. IL-23 and IL-6 derived from dendritic cells or for other sources could promote Th17 cytokines that would then promote autoantibodies. There is also the intriguing possibility of local immune complexes. Now, if you think of it, our patient with subcutaneous anti-IL-5 mepolizumab, if theoretically it does not neutralize the local IL-5 production with an abundance of the antigen, i.e. IL-5, that is numerically more or quantitatively more than the antibody, which is the anti-IL-5, it's possible that you may have local anti-IL-5, IL-5 complexes that might further contribute to a B-cell cluster expansion and induction of ILC2 cells, which should further promote Th2 cytokines maintaining B-cell cluster. It's all theoretically possible, it's a bit far-fetched. But putting it all together, what my laboratory is studying is mechanisms of persistent airway eosinophilia. And the way we have organized our clinics is to understand patients with a hematological mechanism. We would see them in a once-a-month clinic, joint respirology hematology clinic, where these patients who would be tested for T-cell receptor rearrangement abnormalities and abnormal receptor tyrosine kinase signaling, which would make them candidates for therapy with alpha interferon or imatinib. Patients who have steroid hyperresponsiveness may be due to a decreased HDAC activity, which would predispose them to recurrent infections, and as we discuss, infections directly or indirectly may contribute to steroid hyperresponsiveness. And of course, neutrophil would be an innate immune response to any infection. IL-17 and IL-23 that are produced in response to an infection would further contribute to steroid hyperresponsiveness. When we have airway eosinophilia, what do we clinicians do? We give more steroids, because that's all we can do at the moment, which would promote further neutrophilia, would not control the eosinophilic response in these patients because they've got a steroid hyporesponsiveness. An inherent macrophage dysfunction, which we didn't go into with the complete leukotriene, the cystinoid leukotriene and PGE2 metabolic pathways, or by upregulating microRNAs, may further lead to steroid hyporesponsiveness. Infections may directly contribute to eosinophiliopoietic cytokine induction by stimulating T cells. We haven't gone into that data, possibly through TLR signaling. And finally, autoantibodies directed against eosinophil peroxidase and loss of immune tolerance, perhaps mediated by IL-23, may lead to steroid hyporesponsiveness. So my current and future efforts are to first confirm the measurements as simple point-of-care test by developing bioactive paper. The other direction of research is metabolomics, to measure, to come up with devices that would quantify airway eosinophilic activity using breathometers or electronic nose. I'm not involved in that research. It's being led by Stephen Fowler's group in Manchester and by Peter Sturck's group in Amsterdam in the Netherlands. And once you identify persistent eosinophilic activity, target the eosinophiliopoietic cytokines and T2 cells using monoclonals. Study the relevance of this local autoimmunity, B-cell cluster, and the IL-23 and IL-17 pathway. We have just received funding to do a clinical trial specifically to block the IL-23, do bronchoscopies to study B-cell cluster expansion, and characterize the microbiome in these patients with autoimmune formation. Identify airway infections by molecular techniques, and study the relevance of why anaerobes particularly are more predominant in these patients with severe prednisone-dependent asthma, and if anaerobes specifically can mediate steroid insensitivity more than other organisms. And we believe that capsulated pneumococcus and anaerobes are more capable of mediating steroid insensitivity than the other organisms. Examine the interactions between HDAC, microRNA, and infections, and finally evaluate novel strategies to treat these infections and examine their steroid-sparing effects. This work would not have been possible with the collaboration of a number of people. Roma Semi, who I collaborate with in enumerating progenitor cells, Mike Surratt, who is a molecular microbiologist at McMaster, who does the 16S deep sequencing, Don Bowdish, who is a macrophage biologist, Jim Mahoney, who is a virologist, and Paul Foster in Australia, who helps with all the microRNA work. 3 postdocs in the laboratory, Manali, who does most of the autoimmune work, Steve Smith, the ILC2, Hugh Fang, a clinical respirologist from Singapore who does all the clinical assessment, and David Bueller, who also works with the autoimmune work, and my research coordinators and laboratory technologist, and funding from the Canadian Institute of Health Research, the Canada Research Chair Program, National Centre of Excellence for Allergy, Immunology and Food Allergy Network, headed by Judah Denberg, and support from industry partners for all these investigator-initiated clinical trials using monoclonals. And finally, I've got to acknowledge my mentor, Freddie Hargreave, who is toasting the eosinophil with his friend Harry Morrow Brown, who you probably do not know, who was an allergist in Yorkshire in England, who in 1957 first demonstrated the utility of using sputum cell counts in managing patients with airway disease. He challenged the mighty MRC, who in 1956 had published a paper that steroids are not effective in treating patients with asthma, and had Harry Morrow Brown not done his study, we would not be using steroids today to treat patients with asthma. He passed away 3 years ago, and to the month that he died, at the age of 95, he used to examine wet smears of sputum using a microscope right next to his clinic to guide steroid treatment. And here we are in the 21st century, when we can split atom 3 ways and clone DNAs and turn sheep into blood cells into fibroblasts and whatnot. We find sputum cell counts difficult. I think it's very ironical. Thank you very much.
Prem, all I can say is the next time you come, bring the good stuff. Go ahead with questions.
I have 2 questions. One is, where do anaerobes live in an airway unless there's walled off little pockets? And the second is quite a few years ago, probably most of the fellows don't even know, there was talk of local IgE production in the airway. And that research sort of died, but is that these same cells that we're seeing come back now?
So the first question is very, very intriguing. So that's exactly what we are trying to do, to image the pockets of anaerobic metabolism using a sophisticated MRI technique to assess local oxygen utilization in these patients with severe asthma. So it's a very, very relevant question. Why are there pockets of anaerobic metabolism? Why is it that lung, an organ that's well ventilated, would promote this when we aspirate? There have to be aspiration, mouth organisms go in, but why do they flourish, particularly in these severe patients? So we know that it might be these areas that are poorly ventilated or slow emptying, but why is it, could we do anything to improve that? That's exactly what we are planning to study in collaboration with Grace Baraga at the Robarts Institute in the University of Western Ontario in London, Ontario. So we are trying to do that study as we speak. The second, I do not think they are the same population of IgE producing cells because these particular autoantibodies were not IgE. They were largely IgA and IgG. So no, I do not think they are the same population of cells, but it's indeed plausible that there is local autoimmunity, local IgE production. We haven't been able to demonstrate that, but other groups in London, King's College, and at largely King's College, Hannah Gould's laboratory, have shown these IgE repertoires in bronchial mucosal biopsies. And they've just finished a study, they haven't published it, of the efficacy of mepolizumab in patients who are non-atopic, defined by the traditional methods. Now, having said that, they say efficacy, it's very modest. So it's not the same level of efficacy that one would expect in patients that we currently give mepolizumab, the classic IgE-mediated disease. I haven't seen the data in full published form. I've only seen abstract at a presentation. So yes, it is possible, but I'm not talking about the same cells. Yes.
Given that many of us are not getting sputum samples, and especially in pediatrics, it would be more difficult. How much of this do you think you can find in the nose, either through nasal brushings or nasal lavage? Do you be able to pick up on the same neutrophil versus eosinophil, ILC2s?
So the ILC2 cells might not, so I mean, it's not been done, it's possible. So first thing, it's a very important question. Blood may not truly reflect, so I don't think it's going to be as reliable in patients with severe airway disease, although from an industry point of view, the way we are going to be taught how to prescribe these monoclonals is based on a blood eosinophil, which might be very misleading, and I would advise a lot of caution in giving monoclonals based on simple blood eosinophil of modest levels of 0.15 absolute eosinophil count. The nose might be sufficient. We and others have looked at the correlation between nasal eosinophilia and airway eosinophilia. The problem again is that patients with severe eosinophilic disease, the sort of patients that I'm talking about, do not have the classic allergic rhinitis. The single important clinical correlate is chronic hyperplastic rhinosinusitis, usually without polyposis, not with polyposis, not with the classic allergic rhinitis. So they may not have much of nasal secretion. But if they do have nasal secretions, I think it would be a good correlation with airway eosinophilia that has been demonstrated. And you don't need to do a lavage, you just need to do blown nasal secretion, just get them to blow their nose and process it exactly the way we do sputum. The problem again is how you process sputum. We need to get cytospins rather than smears. Smears has been used for hundreds of years. It gives you a qualitative idea, it is not quantitative. You can identify eosinophilia, but it might be difficult to use as smears or bronchoalveolar lavage fluid for that matter for monitoring response to treatment because you do not have a denominator to compare. That has always been the problem. So I think what is going to happen in the future would be some way of point of care test, breath test for children, or what we are working on, which would be paper dipsticks, or something that we're very close to getting accepted in Jackie, is urine metabolomics, particularly for kids. In collaboration with Daryl Adamko, who is a pediatric allergist in Saskatoon, we have characterized the metabolomic profile in urine, and this is able to clearly identify patients with steroid responsive condition and non-steroid responsive condition, asthma and non-asthmatic condition. And the advantage of that technique is theoretically you could apply it to kids 1 day old by squeezing urine off their diapers if you wanted to. So I think the technique is going to be available in the next 3 or 4 years.
You know, the only inflammatory marker that most of us use, and even many don't, is nitric oxide. And, you know, trying to separate out neutrophilic versus eosinophilic, have we looked at that and trying to, narrow these down to a certain population based on nitric oxide?
So it's a very good question. So unfortunately, in these prednisone-dependent patients who require the sort of patients I talked about, who have recurrent infective bronchitis, exhaled nitric oxide has not been very useful. In the patients with milder disease, patients on low-dose inhaled corticosteroids, so perhaps up to about 800 micrograms of budesonide, nitric oxide levels greater than 50 parts per billion is indicative of further steroid response. But in patients who are prednisone dependent, unfortunately, it has not been useful. Now, there are 3 recent studies looking at the predictive value using ROC curves of NO levels of eosinophilia. And the overall prediction, there are 3 papers, one from the South North Carolina group, Chapel Hill, one from Peter Stokes' group, and another one from, again, Stephen Fowler's group, all published just recently, showing very poor predictive value of about overall accuracy of about 6 to 7%, which is not bad, so that's the best we have at the moment.
What are some of the other targets of the microRNA 9 that could, some other genes or protein pathways that could be involved in the steroid insensitivity?
So we haven't done any work, so I got excited. I've got to admit I'm very new to this whole research of microRNA. I'm just learning. MicroRNA 9, one of the targets happens to be HDAC2. So if you target microRNA 9, you could possibly improve HDAC activity as well. But the problem, I was talking to a neuroscientist who works in ALS, who cautioned me about targeting directly microRNA 9 because that could promote motor neuron disease. So it's a very tricky situation. So I think the strategy would be not to target microRNA 9, but to increase the protein phosphatase catalytic activity that is specific to steroid sensitivity, rather than directly targeting microRNA 9. So short answer to the question is I do not know. I thought we would do clinical trials on microRNA 9, but I've been cautioned not to, and I will respect that caution. So we'd rather. So I was told that your breathing might improve, but you may not be aware that your breathing has improved. So it will be a dreadful situation.
Let's see, a question someone has sent in here by computer. How confident can you be that sputum samples are not reflecting post-nasal drainage, or that nasal and pulmonary mucosa, are they similar enough that it doesn't matter?
No, so the induction process is very rigorous. We make the patient wash their mouth and gargle before we make them spit. They're encouraged to blow their nose before we induce collect sputum. And the morphology of cells, the mononuclear cell population would suggest if there is nasal contamination. So we would be very, very confident that the samples that we collect are largely airway secretions and not contamination from nasal secretion.
Do you employ the exhaled breath condensates?
We do. So
with these at the same time, or?
So we do. So in part of the inflammatory collection, we do 2 additional measurements: exhaled breath condensate collection and exhaled breath temperature. Problem again with exhaled breath, so we've got the data. It's a large manuscript on infective exacerbation. I didn't go into that. It is currently under review in thorax. I'm not confident to recommend exhaled breath condensate pH for clinical decisions. What we know is that if the pH is low, something bad is going to happen to the patient. The patient would tell us that anyway. The peak flow would tell us. That's all I could glean from the pH measurements. So something I could not be confident enough to tell if it is going to be an infective or non-infective exacerbation. So if the pH is low, something bad is going to happen to the patient. And John Hunt from Charlottesville has also shown that even in ventilator patients, that inability of acidification or buffering of airway pH is a predictor of poor response. But we are not quite there to say if it is going to be a steroid responsive or non-responsive condition. Temperature is still very early days.
Have you had a chance to look at any patients undergoing chemotherapy where their eosinophils are removed or their neutrophils are severely neutropenic to see what the changes in their sputum represent?
No, I haven't done that. But having said that, we published a clinical trial last year specifically targeting neutrophils to understand the relevance of neutrophils to severe asthma biology. So we did a clinical trial of 33 patients with severe asthma with neutrophilia that we proved was not due to an infection, and gave them a CXCR2 antagonist, small molecule antagonist, specifically directed against the IL-8 receptor. And we were able to demonstrate a 45% reduction in airway neutrophils and about 40% reduction in blood neutrophils, which was transient, but the asthma didn't get better, implying that the neutrophil is probably not directly contributing to the asthma biology. But we haven't systematically looked at the airway profile in patients who have received chemotherapy.
I just wonder if you took Cleveland people. That's fabulous.
Thank you again. I just, every time I talk to you, every time you come here, your depth of knowledge and the amount of research that you do, as well as being a full-time clinician, is just absolutely amazing. So thank you again.
Thank you very much, Len.